Good evening, everyone. Welcome to this evening's webinar. I'll just wait for a moment or two just for everyone to get joined in, and then we'll get underway. Thanks, Audrey.
And I wanted to turn up.
So you're very welcome to this evening's webinar. Thank you for joining us. This evening, we are going to look at the topic around medication management for patients with intellectual disabilities. So you're very welcome to this evening's webinar. As always, when you join, we ask you to ensure that you are muted. We have recorded this evening's webinar and it will be posted to the website in the coming days. If you're having any issues this evening, it might be a good idea to leave and then come back. And we have Audrey sitting here in the background as well to assist you if necessary with any connectivity issues that you might have. We're happy to take questions during the webinar. If possible, unless it's a burning question, if you could leave it to the end, we will have some time for questions at the end. And there is a chat button just at the bottom of your screen where you can type in questions. We'll share a survey link afterwards, and we would welcome any feedback you have on this presentation and any future webinars you would like to see delivered with the IAOP. So moving on to our speakers then this evening. We're joined by three fantastic speakers who have vast experience in the area of managing medicines for individuals with intellectual disabilities. So they are Dr. Máire Dwyer, who's Assistant Professor in Pharmacy Practice, School of Pharmacy in Trinity College, Juliette O'Connell, again, Assistant Prof in Pharmacy Practice in the School of Pharmacy, Trinity College, and Bernadette Flood, who's a Senior Pharmacist at Avista, formerly Daughters of Charity. So Máire and Juliette will lead on the presentation to start with, and then we'll move to Bernadette afterwards. So there might be just a little gap as we transition between the two sets of slides from the presenters this evening, so do bear with us as we work through that. So without further ado, then I'll turn to Juliette and Máire to get us underway. Thank you. That's lovely. I can see that there.
Great. So thanks very much for the opportunity to present this evening. So the title is Intellectual Disability Pharmaceutical Care Consideration. I'm going to speak first for around 10 minutes, and then I'll hand over to Dr. Máire Dwyer, and then Dr. Bernadette Flood will finish up with the practice consideration for care of people with intellectual disability. So we're going to start with the learning outcomes. So we're going to be describing the prevalence and nature of intellectual disabilities in Ireland, provide an overview of patterns of medication use in adults with ID, outline specific risks associated with medication use in adults with ID, and describe everyday challenges associated with medication use and the practical solutions for adults with ID. So I'm just going to begin with a definition of intellectual disability. So it is a neurodevelopmental disorder which manifests early in life and is characterized by impairments of general mental abilities that affect adaptive functioning. So when we discuss intellectual disability, we consider three domains of function that are primarily affected. So we have conceptual skills, which includes language, reading, writing, mathematics, knowledge, and memory. Social skills, including communication, social judgment, and forming and maintaining relationships. And practical skills, such as self-management and personal care, money management, etc. So historically, the most frequently used criteria for diagnosis of ID were intelligence quotient IQ below approximately 70, along with impaired social skills and onset before age 18. However, the reliance on IQ tests alone for the diagnosis of ID has been superseded with better metrics for the level of adaptive behaviour deficits. So we no longer solely go by IQ for diagnosis of intellectual disability. So this is an overview of the etiology of intellectual disability. So it is generally categorized into 3 areas. There are genetic factors, hereditary factors, and acquired factors. So the genetic factors include chromosomal disorders, and that includes Down syndrome, which is the most common identified cause of ID. But there are other chromosomal disorders, including Cornelia de Lange syndrome, Fragile X syndrome, Prader-Willi syndrome, Angelman syndrome, and Turner syndrome, among others. Then you have hereditary factors. So these are typically diagnosed neonatally through metabolic screening and include conditions such as phenylketonuria. And then acquired factors are further subdivided into congenital, developmental, or environmental. Congenital factors include neonatal hypothyroidism, fetal alcohol syndrome, rubella, syphilis, toxoplasmosis, or herpes. When we look at developmental and we look at prenatal conditions, pregnancy complications such as toxemia, uncontrolled diabetes, intrauterine malnutrition, placenta previa, and umbilical cord prolapse can all be causes of developmental intellectual disability. Perinatally, birth complications like asphyxia or incorrect use of forceps can cause ID. And postnatally, there can be brain damage from jaundice, which is called kernicterus, and infections can all cause ID. And then when we look at environmental factors, as poverty, these can affect the quality of natal care and could contribute to the development of ID. What is important to remember is that identifiable causes of ID are usually only accounting for a minority of cases. So you could have 60% of people with ID who do not have a known cause of ID recorded. So these are just some figures on the prevalence of intellectual disability. So worldwide, you can see a fairly broad range there, 0.05 to 1.55%. And that's coming from a systematic review. And of course, that would depend on the quality of the studies that were included. But the rule of thumb is generally around 0.5 to 1% of the population would have intellectual disability. When we look at Irish data, data can be extracted from the National Ability Support System. So the National Ability Support System replaces 2 disability databases that were previously in use. And they were the National Intellectual Disability Database and the National Physical and Sensory Disability Database. The NASS is replacing both of those. So it doesn't solely look at individuals with intellectual disability, but it looks at users of health service executive disability funded services. So there were 36,649 service users reported for 2020. 22,746 of those reported intellectual disability as their primary disability, with a further 927 reporting intellectual disability as an additional disability. So that equates to approximately 0.5% of the population. And just there is a note on that the information for 2020 is still incomplete because they're still setting up that National Ability Support System. So people with intellectual disability live in a range of different types of residence. And in 2011, national policy was rolled out called Time to Move On from Congregated Settings. And the aim of this was in order to promote deinstitutionalization of people with intellectual disability. So moving them out of congregated living settings into the community. So that can have an impact then because you have more people with intellectual disability who are accessing primary care health, whereas previously the services would have typically provided the healthcare for people with intellectual disability. So people can live independently. They might be living with family who might also be acting as carers. They may live in community group homes. So these are typically settings with less than 10 people living in a home in the community with support from care staff and nursing staff. And then residential or campus type settings. So this could typically be a variety of houses within a single campus where people with intellectual disability live and have carers and nursing staff come in. So there has been a movement away from those residential settings into those more community-based settings over recent years, and that's continuing. People with intellectual disability also access a number of services. So they may access day service, which is an opportunity for them to engage perhaps in employment and also to socialise with other people. And they also may access overnight respite if necessary. They also require specific supports for daily living and also specialised supports within the realms of healthcare. So there are a number of different services that people with intellectual disability use. So people with intellectual disability will experience different patterns of medical conditions to people within the general population. So two categories of morbidity experienced by people with ID have been suggested, and these are associated or primary health conditions and secondary health conditions. So the associated health conditions would refer to conditions that are directly related to the intellectual disability. So that includes epilepsy, mobility problems, for example, in the case of a person with cerebral palsy, visual impairment, hearing impairment, mental health conditions, dementia or hypothyroidism. And some of these are considered syndrome-related conditions, which are conditions co-occurring in an individual with ID that may be genetically related to the presence of that ID. So an example there would be hypothyroidism in people with Down syndrome. Secondary health conditions then are those that occur at higher rates in people with ID than in the general population, but they're considered to be preventable. So those include things like obesity, gastroesophageal reflux, constipation, dental caries, pneumonia, and bowel obstruction. Life expectancy in people with intellectual disability has been found to be 19 years lower than in the general population. And people with intellectual disability also experience multimorbidity. And 7 out of 10 adults with intellectual disability over 40 experience multimorbidity. And this has been found in the Intellectual Disability Supplement to the Irish Longitudinal Study on Aging, which Dr. O'Dwyer will be elaborating on very shortly. And the most prevalent comorbidity would be co-occurrence of mental illness with neurological disease in people with intellectual disability. So there are a number of health disparities there that have been identified. This slide just shows a comparison of the percentage of the population using medications from a range of pharmacological groups and a comparison with adults with intellectual disability. And the first that I'd like to highlight there is cardiovascular system agents. So you can see there that there's significantly different pattern of medication use in cardiovascular system agents. And this is something that has also been mirrored in the IDS-TILDA study. And it is hypothesized that it's perhaps because people with intellectual disability have different stressors in their life and that could affect cardiovascular health. Whereas then when we look at the nervous system, you can see there's a huge difference in the percentage of individuals exposed to medications which act on the nervous system. So 17.5% in the general adult population, but nearly 50% in adults with intellectual disability. So those are the patterns of medication use that we often see, and it's typically linked to psychotropic agents such as antipsychotics and anti-epileptics. This is another slide that shows a little bit more clearly the differences, and particularly the differences across the age ranges of people with intellectual disability and medications that they use. So you can see for the cardiovascular system there, the gap grows as the ages increase between intellectual disability populations and the general population. And then the nervous system agents are another area where you see a huge difference there in the prescribing of pharmacological agents between the two populations. People with intellectual disability are also more likely to experience drug-related adverse effects, and it's been found that they're more likely to suffer from movement-related adverse effects from antipsychotics. So the drug-drug interactions is one of the reasons for the increase in adverse medication effects. There's also potential for increased body fat to affect pharmacokinetics of medications in this group. The underlying neurological damage that exists in people who have an intellectual disability can alter their sensitivity to medications. Genetic abnormalities and expression of metabolic enzymes can also change the way that medications act in this population and can cause a different profile of adverse medication effects. And one of the very important points that we need to consider when we're helping people with intellectual disability is that they may not always be able to communicate the adverse medication effects that they are experiencing in the same way that someone from the general population would, which can make it difficult, and it can lead them to be predisposed to the prescribing cascade. So the prescribing cascade is where a new medication is added in order to manage, for example, the adverse effect of an existing medication. Particularly in people with intellectual disability, this could take the form of, if they're prescribed an anticholinergic agent or a number of anticholinergic agents, one of the adverse effects they may experience there is constipation. The discomfort then that's caused by the constipation and the difficulty that the person may have in communicating that to a healthcare professional could be misconstrued as what we call challenging behaviour, which means that the patient may be prescribed an antipsychotic to manage that challenging behaviour, which may cause movement-related adverse effects, leading to further prescription of anticholinergics. So not only is it a cascade, but it can become a cycle for an individual where the key issues are not actually being addressed, they are being managed by addition of further medications. And this is something we have to be very aware of when we're providing care to people with intellectual disability. So I'm going to pass over now to Dr. O'Dwyer to discuss some of the findings in IDS-TILDA and some of the other research that's ongoing.
Perfect. Thanks very much, Juliette. So I'm just going to present a few slides of some work Juliette group in IDS-TILDA in Trinity have been working on in terms of medication use in older adults with intellectual disability in Ireland. So we have a study that's based in Trinity of 753 initially adults over 40 years of age with intellectual disability in Ireland. That's nationally captures health, social, all the different variables in someone's life. And it's also designed to be comparable with the Irish longitudinal study of aging. You may have heard of it, TILDA. So this offers a really good opportunity, probably for the first time in Ireland, to look at medication use in a representative intellectual disability. So our first study, at the baseline of the study, we found that the vast majority of older adults with intellectual disability experienced polypharmacy. So we defined polypharmacy as 5 to 9 medicines, and then there's definitions as 10 or more medicines polypharmacy. So in particular, quite a large contrast with the general older population, where over 1/5 of older adults with intellectual disability were taking 5 or more or 10 or more medicines, compared to 2% in the general older population. And just in case, during the age of 40 and over was chosen compared to 50 and over for the population with intellectual disability in Ireland, similar to what Juliette said, due to reduced lifespan, in kind of inequalities in health, and also earlier onsets of certain age-related conditions like. So what we also found from the IDS-TILDA study that was interesting was that also the most frequently reported medicines were quite different to the general older population. So you'd be familiar with in the within TILDA, the most commonly used medications were cardiovascular related medications, so the lipid modifying agents, antithrombotic agents. Whereas in contrast, in the older adult population with intellectual disability, antipsychotics were most commonly used. Persisted. There have been 3 other waves since, and this has remained consistent, where over 40% of the population were exposed to antipsychotics. That was followed by almost 38% been exposed to anti-epileptics. This reflects a much higher prevalence of epilepsy in older adults with disability compared to the general population. So about 3 in 10 have epilepsy, and that was compared to around 1% TILDA. And then that was followed by a very high prevalence of use of laxatives, reflecting high prevalence of constipation, and also a lot of the work examining the impact of different medications and the need for laxatives. We did a study focusing particularly on psychotropic use in the population. These were the most frequently reported medications and were reported far in excess of the general older population, reflecting in part much higher prevalence of reported mental health conditions. So we were also quite interested when we were looking at the data in the overlap between the use of the different psychotropic medications. So we could see that they were often not been used just one psychotropic. There was sometimes use of 2 psychotropics within the same class, use of multiple psychotropics. So we found of those with a psychotropic use, 62% had interclass polypharmacy. So meaning taking at least 2 medications from different classes. And this was just a Venn we completed, trying to kind of visually depict the complexity associated with the medication use. So 15 participants taking together an antipsychotic, an anxiolytic, a mood stabilizer, and an antidepressant. So this may be necessary, but of course this comes with lots of risks of drug interactions and impact on quality of life, on maybe this constipation. We also have continued to look at the anticholinergic burden of medications, so the cumulative effect of medications with anticholinergic effects and how they affect the potential and peripheral side effects. So we captured the cumulative burden of every participant in the IDS tilde study at wave 1, and we ranked it having no anticholinergic exposure, having an exposure of 1 to 4, so that would be considered a moderate anticholinergic exposure, which would be considered quite a high exposure. And we found a number of associations, so a significant association between having higher burden and the participant been more likely to report daytime dosing during the day, which would also present, risks with falls and quality of life, and quite a that has persisted through the waves with chronic constipation and the use of multiple laxatives. So Juliette, as part of her PhD, looked at quantifying the cumulative burden of sedative and of all the medications people were taking in wave 2 of the study. And this drug burden index has been validated and has shown significant effects with health and quality of life. So after adjusting for the different confounders that could influence, Juliette found that associated with lower independence in, activities of daily living, and that was measured by the Bartel index. So even when taking into account other things that could having an increasing burden of sedative and anticholinergic medications still was having a significant negative impact on independence. Just to finish in terms of this part with 2 kind of more studies we had done. Mentioned antipsychotics were the most frequently reported medicine in the IDS tilde study. At all waves of the study, they have kind of consistently remained over 40% of the population taking an antipsychotic. So at wave 2 of the study, 45% of people reported an antipsychotic. With 5th, we're actually taking 2 or more antipsychotics with a maximum of 3. And these medications were not been used in isolation. In older adults, people were also taking an average of 7 other medications. So, lots of different pharmaceutical care issues there. Reporting of mental health conditions, so that is some limitation. We try to understand, so we don't have the direct reason for use of the medications, but try to look at, licensed indications for antipsychotics. And we found that of the 305 participants taking an antipsychotic, around 1/4 of them licensed indication as a psychotic condition. A lot of the other participants had other mental health conditions, and then also, and Bernadette may touch on this, quite a significant proportion, 67%, were reporting behaviours which challenge. So there is, we don't know the reason for prescribing. They are being used off-label for behaviours. In terms of the factors, we conducted a model taking into account other things that would influence use, but we found that having Down syndrome, those with Down syndrome were significantly less likely to report an antipsychotic. In other literature as well, with lower reported prevalence of mental health condition in people with Down syndrome. Also, and this is something consistent throughout a lot of the work we've done with medication use, in particular psychotropics, that the place of residence had a significant impact. So in this case with antipsychotics, those who lived in community group home or residential settings were significantly more likely to report an antipsychotic compared to those who lived with their family or independently. And behaviours with challenge were also significantly associated with use. Just to finish, just to give an update on a study we're doing at the moment, looking at the long-term quality use and impact of psychotropic use for adults with intellectual disability. So this is a Health Research Board secondary data analysis project that we are completing at the moment. And we have Pharmacist, which is great, involved in our steering group, working with the HSC National Clinical Programme for People with Disability and the College of Psychiatrists of Ireland, the Learning Disability Faculty, and patient stakeholders to look at the long-term impact of medications using the 10 years of the IDS-TILDA study and some linked data from the HSC PCRS. And we're hoping to develop some medicine use guidelines after we've determined the long-term effect of these medicines to improve medicine use in this area. So I'll just move on now to Bernadette.
Fantastic, Máire and Juliette, thank you for that. Bernadette, I think you're sharing your slides when you're ready, aren't you? You're just muted, sorry. There we go, lovely.
Just come up as your email there, Bernadette. Perfect.
Thank you.
You're just still on mute if you want to unmute yourself. It's on the bottom left-hand side of the screen.
Sorry.
No, you're okay.
Not sure what's happening here. Sorry.
Oh, you're grand. You had them up there a second ago, so they should be close.
Ah, well. All right, great. Is that it? Can everyone see those now? Brilliant.
We can indeed. Lovely.
Great. Thanks very much, Máire and Juliette, for a spellbinding introduction to the topic of medication use in people with intellectual disabilities. It's a very complex area, as you've probably gathered from what Máire and Juliette mentioned. So they've kind of set the scene, and I suppose the context of what they've both said is that it's very complex, and it's an area in which there are huge health inequalities and health inequities. So health inequities, as we probably all know, are avoidable and there can be interventions put in to try and curtail their development. So pharmacists would have a role in doing something like that. What I'm hoping to show later on are 2 examples where life and death situations do arise for people with intellectual disabilities. And I hope to finish off with a few examples for the future where pharmacists could help. So just to put it in policy context, Healthy Ireland is the framework for improved health and well-being in Ireland. And it's a major health policy, and it supports actions to increase the proportion of people who are healthy at all stages and protect the public from threats to their health, and to reduce health inequalities. And we saw from the information that was presented already, there are huge health inequalities in this population group. Health inequalities result in differences in mortality, and there are huge differences in mortality in the population with intellectual disability as compared to the general population. People with intellectual disability can die up to 45 years earlier than the general population. And in England, the median age of death for people with intellectual disabilities is actually about 25 years younger than the general population. So it's a serious health issue. Why do health inequalities occur? Well, the ability for people to stay healthy is influenced by smoking and diet, access to services such as pharmacy, social deprivation, access to work, educational levels, social networks, and how much control people feel they have of their own lives. The actual determinants for health inequalities for the population with intellectual disabilities have been discussed and developed. And it's been found that people with intellectual disabilities have the greater risk of exposure to these social determinants of poorer health. They've increased risk of health problems associated with the specific genetic and biological causes of intellectual disability that Juliette went through earlier on. They have huge communication difficulties and reduced health literacy, which jeopardizes their access to healthcare. They have personal health risks and behaviours such as poor diet and lack of exercise. And there are deficiencies relating to the access to healthcare provision. And this can include pharmacy and pharmacists. So as Máire showed, medication use is the main therapeutic intervention really in this population, and people with intellectual disabilities are thought to be the most medicated group in society. That can be to their benefit, but can also be to their disadvantage. So obviously then pharmacists have a role to play because medication is such a big influence in this population. And the National Patient Safety Agency in England interviewed some people with intellectual disability and found that they reported that often they do have helpful pharmacists who helped them understand their medication, but that too often the picture was of prescribed medications with little information. And it's really important for pharmacists to understand the patient experience. And it can be really difficult for people with intellectual disability to understand what the role of the pharmacist is and how they or their carers can get their most from pharmacy services, no matter where they are, whether in the community, in hospital, residential care. And pharmacists should be aware that people with intellectual disability may not know that they can actually ask questions of pharmacists, and they may lack the vocabulary to explain what it is they want from their pharmacist. And Juliette showed us statistics about the poor health literacy and communication skills in the population. And it's important to notice that carers are really important in the care of people with intellectual disabilities, and as well as the person with intellectual disability lacking confidence, the carer can lack confidence to contact the pharmacist as well. It's a very complex area of care, and on the other side, healthcare professionals such as pharmacists do not understand regularly the complexity of the tasks that they ask people with intellectual disability and or their carers to do. Giving medication and taking medication can actually be quite complex. But it's been found in Ireland, thankfully, that good access to accommodating pharmacy services makes a positive difference. The next two slides show work from a study in the School of Nursing in Trinity, where the researcher interviewed 15 mothers of children with severe and profound intellectual disabilities. Interviews were undertaken and the mothers kept a diary, and the aim of the study was to explore the lived experience of giving medicines to children with intellectual disability. The research found multiple themes, one of which gave insight into the importance of supportive relationships with health professionals. And it was found that the GP, the local hospital and the pharmacist were key in providing supportive elements to the mothers in their daily roles. And the pharmacist was actually central to the daily activities relating to the giving of medicines, and a good relationship by the mother with a pharmacist resulted in a much happier mother. And the same study found that there were challenges experienced by mothers giving medicines to children with profound disabilities. And towards the end of the research paper, they identified what they felt was needed from pharmacy. So a GP and a pharmacist learning package for training and education of the needs of children with severe and profound intellectual disability, and something that indicated the intricacies of giving medicines to this cohort. Continuity of relations were encouraged between pharmacists and individuals, and the big thing they identified was having the same pharmacist in each location dealing with the specific child. And then the development of a pilot scheme for community pharmacy to educate about the home management of medications. This could include, the parents thought, issues about compliance, medication interruptions, how you actually manipulate medications carefully, and the administration of medicines. Because medicines are such a big part of the lives of people with intellectual disabilities and their carers, it's important that the quality of the medication use process can be of the highest quality possible. It's very complex. And it's important to note, as Máire showed in her slides, that people with Juliette showed, people with intellectual disability live in many different locations, but the quality of the medication use process will vary depending on the location in which it occurs, the processes that are actually involved, and the personnel who are involved in the processes. I did some work a few years ago myself where I interviewed 6 people with intellectual disabilities and identified some themes. I looked at the medication use process and discovered that there's a very significant pre-prescribing component to the medication use process in people with intellectual disabilities. The issue of healthcare by proxy and diagnostic overshadowing are really important for pharmacists to be aware of in this population group. Healthcare by proxy is where usually a person with intellectual disability is depending on another person to bring their care or concern to the attention of the relevant healthcare professionals, such as the pharmacist or the doctor or the speech and language therapist. And then the other major issue in the population is diagnostic overshadowing. Diagnostic overshadowing is where everything is put down to the person's intellectual disability. That's seen as their main diagnosis. So if their behavior changes or they do something out of character, you know, people can say, oh, that's just the way they are, or oh, that's just because if they're intellectually disabled, which puts them at a huge disadvantage. Also, it depends on their carer being a very receptive person and understanding and having the confidence to bring them to the healthcare professional. So as we saw from the earlier slides as well, prescribing in this group occurs in GPs, surgeries, disability services, mental health services, diabetic clinics, epilepsy clinics. Dispensing occurs in community pharmacies, residential services, specialist services, hospitals. Administration, and this is really important, can occur by the person themselves, can by family members, or by paid carers. So depending on the environment in which they live, if they're being given medication by a paired carer, it's important for the pharmacist to know, is it actually a registered nurse who's administering the medication? Is it a social care worker who may only have had a few months training in relation to medication? Is it actually a healthcare assistant who's actually only had a very short educational experience? Is it a care staff who has no training? So for pharmacists providing medication for people with intellectual disability, these are actually really important issues to understand who's giving the medication and what knowledge and skills have they in this area of care. Documentation will obviously depend on the area as well. And then monitoring becomes really important as well, because if the person is being cared for in a disability service, you would assume then that the people providing care and support have some training in intellectual disability, but they may not. And then other healthcare services such as specialist clinics, one would hope would be aware of the issues in disability populations. GPs, surgeries, they mightn't see that many people with intellectual disabilities. Pharmacists, some community pharmacies might never see a person with intellectual disabilities, or might only see the carer of the person with intellectual disabilities. And then social care settings can undertake some monitoring as well. So as you can see, there's many different variables and there's lots of different variations in the different patterns in the process. In the service I worked in, I did an audit a number of years ago. This is just to give you a reflection of what happens in residential care. At the time, there were 129 residents in the centre, and I counted every single tablet and medicine that was administered during the day. In 28 days, 31,614 medicines were administered in the centre. The average number of medicines administered per person in the 28 days was 245. And the range of solid medicines administered per person in the 28 days, was between 0 and 896. So that means that one lady was actually getting 896 tablets and capsules in a 28-day period. That actually is an extremely complex task for in the centre I work in. Medicines are administered by registered nurses. For the nurse to administer that amount of oral medication safely is hugely time consuming, very complex. And for the person trying to swallow that amount of oral medication, it's really complex and time consuming as well. So you can see the other details later on if you're interested. So how can a pharmacy support people with intellectual disability and or their carers or care workers? So the important thing is to practice person-centered care no matter where you're working, and try shared decision-making with the person and or their carer and ask them what actually works for them. Ask what supports the people need rather than assuming that you know the answer already. And accept that you may be an expert in medicines, but you may not, and probably are not, the expert in that person. The person themselves, their parents, if they're children, and their care workers are the experts, and they should be used as a valuable resource. And I suppose we should all ask ourselves, do we tend to speak differently to people with intellectual disabilities who may have physical attributes indicating that they have an intellectual disability? Pharmacists should beware of diagnostic overshadowing, where the the challenges may actually be caused by infection, pain that's undiagnosed, unrecognized, but can be attributed to the behavior pattern that one thinks people with intellectual disabilities exhibit. Medicines, as Máire mentioned, can be contributing with some of their antimuscarinic effects and other side effects, and these can lead to apparent behaviour changes and challenges. Behaviours that challenge can be associated with physical and environmental causes. They don't have to be due to medication. Sometimes changes in the environment or a person's life and lifestyle can have huge implications for a person with intellectual disability. Bereavement is actually a big issue in this population, where as the population gets older, a lot of their friends and companions that they may have shared a dormitory with for 30 or 40 years die. That's a hugely traumatic event in anyone's life, and is hugely traumatic for people who do not communicate in normal ways. We should always seek specialist advice before medications are stopped, started, or switched in this population group. It may have taken years to stabilize people with intellectual disability and allow them to adapt their behavior so that they are accepted in society. And it can be very detrimental to change medication without specialist advice. What can the pharmacist contribute to people with intellectual disability? Pharmacist skills include listening, explaining, advising, and questioning. These are really important. Many people live independently or with just a little support, and they actually need really helpful advice about healthy lifestyles. Medication is used often to combat problems with health, obviously, but if the health problem is brought about by an unhealthy lifestyle, medication may not be the most appropriate answer. Pharmacists have to include education about diet and exercise for both the person with intellectual disability and or their carer. And a small but important percentage of this population have more complex difficulties and have significant physical and mental health problems that requires multidisciplinary collaboration. And these people with these challenging behaviours are some of the most vulnerable people in society. This is just some insights from a discussion group about pharmacists in the UK that had participants who had intellectual disabilities. So the participants found that despite regularly taking medicines, most focus group members with ID were actually unclear why they needed them and how they should take them or how they helped. They explained that pharmacists often spoke to their parents and didn't consult with them. All were unaware that they could ask the pharmacists themselves for information about medicines, and the group members identified that they would like the pharmacist to speak directly to them. During the research I conducted myself, I interviewed 6 people with intellectual disability, and Pat, this gentleman here that I'll talk about for a second or two, or a few minutes rather, was the index case. Pat had diabetes, and he had had a hypo in a shopping centre the weekend before I interviewed him, and he had to get glucagon into his backside, as he said, in public. He hates diabetes. He hates everything about it. He just takes the tablets because I do not want to die. If I die, I do not come back. And he mentioned this numerous times during his interview with me. He appeared to have responsibility for his own self-care. He was on 2 different types of insulin, which he stored in a drawer in his bedroom and not in his fridge. He brought 13 of one type of insulin and 4 other insulin pens into the interview, and 3 glucagon hypo kits, some of which were out of date. He takes his medicines with a yogurt drink that's very high in sugar, and he had 2 glucose diaries with minimal entries in them. He got his medication from 2 different pharmacies, one of which gave him meds in a monitored dosage system, and the other dispensed in the original packs. So he had very confused ideas about how to give medication. This isn't the exact one, but it's like the monitored dosage system Pat used. He hadn't a clue what it was all about and pushed random bubbles out of it when he felt like it. So just to look at some of the issues that can contribute to the health inequalities and health inequities in the population with intellectual disability. As we saw from the mortality figures, these issues are actually life and death for people with intellectual disabilities and can be addressed by different groups, including pharmacists. So the first one I'm going to look at quickly is choking. Choking occurs when we ingest or inhale food or non-food items that cause obstruction of the respiratory tract. The first statement here, woman with ID died after choking on a sweet in a day centre. That happened in Ireland. The next one is about a person choking in a care centre in England when a gentleman choked on his lunch. And then there's another case of a resident choking on thickeners such as Nutilus, where it was left out, the resident got it, and it formed a clog in their windpipe and the person died. So choking is actually a really important issue in the population. Choking episodes are relatively specific to the population with intellectual disabilities in Ireland, and that's from the NIMS system, which looked at the national clinical incidence. I won't have time to go through all this, but there's information there for people who would like to know a little bit more about choking. And the National Patient Safety Institute in our associate agency in England produced a guide that identifies the factors that increase the negative health consequences arising from a person with dysphagia. Dysphagia is a significant risk in the population with intellectual disability. It may be underdiagnosed. And the risk factors with dysphagia are if you have an intellectual disability, if you suffer from seizures, if you have behavioural difficulties, and if you've unmanaged pain, or there are staffing difficulties in the centre or the area in which you're cared for. In the IDS tilde results that Máire and Juliette work with, 17.3% of the participants had actually reported a choking history. And medication use can actually, medication use can actually contribute to dysphagia, so it's important to consider that. Medication review, as Máire mentioned, is an important part of care. Medication administration will be affected by the presence of cognitive, behavioural and swallowing problems. And the other issue that can be a life or death situation for people with intellectual disabilities is epilepsy. There are associated morbidities with people with intellectual disability, and Máire has gone through a lot of the morbidity pattern in this population group. There are many health problems in people with intellectual disability and epilepsy care problems. Multiple medication use is high. They've been exposed to high exposure to drug treatments for mental health issues. A lot of adverse effects from the anti-epileptic drugs, and epileptic care in this population is very complex. And there are problem areas identified for medication management in epilepsy-related deaths. These include no medication prescribed for ongoing seizures, inappropriate choice of anti-epileptic drug, inappropriate combinations, doses too low or inappropriate, unsupervised or inappropriate management of the changes to anti-epileptic medications, little consideration of alternatives, major drug errors. And although 14% had a problem adhering to their drug regimen, there was little to suggest that this important issue was actually discussed often with patients. And this is an opportunity for pharmacists to advocate for patients to stick with their anti-epilepsy regimen. In England, there are over 1,000 deaths from epilepsy every year, and many of the deaths are related to SUDEP. SUDEP is a big problem in the population with intellectual disability, and one of the big risk factors for it is not taking your medication or medication changes. So what can the pharmacist do? We can make reasonable accommodations. We should provide special care in special facilities. Quiet rooms in pharmacies are ideal ways to try and encourage people with intellectual disabilities to communicate. It's actually the law to adjust our care for people who need more specialised care. We must focus on the individual, and we must increase our dialogue with individuals with intellectual disability. It's important for pharmacists to show empathy, patience, and a willingness to slow the pace at which we talk and communicate. It's important in all environments. It's the foundation of effective pharmacy consultations, and it's important especially for people with intellectual disability and their carers who can feel isolated and are at a greater risk of ill health. We should see the person rather than the disability, address them directly. Some people may wish to have their parent or carer involved, and it's important to acknowledge that. And these people can provide valuable information that improves care, should decrease the health inequality gap, and should decrease the risk of serious consequences. Accessibility is important in all pharmacies. Pharmacies should enhance the quality and the accessibility of the service they provide by simple equality infrastructures, have an equality policy, look at equality and diversity, and have a quality action plan. For the future, people with intellectual disabilities require equitable care from pharmacists, but what they really want are equal outcomes. So we have to change the care or advance the care we provide to make sure it's of a quality necessary for this particular population. Pharmacy has a role to play in addressing health inequalities and health inequities. So I'd like to thank the people with intellectual disability with whom I work, IIOP for the invitation, and the audience for your attention. And I'll just leave you with this slide, which shows the difference between equality and equity. Equity is where we treat everyone the same, but it only works as if they all start from the same position. Equity is we recognize difference, and we must ensure equity before we can enjoy equality. Thank you very much.
Thank you, Bernadette, and thank you, Juliette and Máire, also for your presentation. We'll invite some questions at this time. We have a few minutes left this evening before we wrap up, and we'll see if anyone has any questions. I might ask a question, I'm not sure who it's best directed at to start with, about, I suppose, the difference between appropriate prescribing and inappropriate prescribing. And I suppose we know a lot about inappropriate prescribing in maybe older adults. How difficult is it to understand what is inappropriate for individuals with intellectual disabilities and trying to pick that apart? Is it as clear maybe as it is for other populations?
I'll take that for a minute anyway. It's not as easy and as clear, no. It's been found that people with intellectual disability may actually be disadvantaged if guidelines produced in the general population are used in their population because of the high morbidity and mortality, really. The issue, whatever cardiovascular or epilepsy or whatever, it has to be looked through the lens of caring for people with intellectual disability. So unless you really understand what the issues are in the population with intellectual disabilities, it's actually very difficult to make a judgment off the top of your head, really, about it. It's very complex. It's not easy. Juliette and Máire, that's as a practitioner in the area, that's what I would have found. But Juliette and Máire might have learned more from their research.
Thank you. Okay, I don't see any questions coming through in the chat right now. So what we might do then, in the interest of time, is Audrey, if you could pull up the slides and maybe share the feedback link, but do feel free to put in some questions as we do that. So I see a question here which has come in. So in my pharmacy, we deal with two hugely different care homes for people with intellectual disabilities. One is amazing with the same staff, but the other is constantly changing staff, so can be disorganized and makes our job quite difficult. And I imagine it's very difficult for the patients. Any advice on managing that? Bernadette, and maybe this might be some to fall within your remit, perhaps.
It can't be easy. It sounds a nightmare, to tell you the honest truth. I'm lucky I work somewhere where the staff is pretty stable, and I'm the full-time pharmacist there, so I would find I'm in control of things. Doing it at a distance and maybe not the pharmacist having to deal with different staff all the time must be very confusing. I suppose protocols and guidelines, making sure that say if you have a patient with dysphagia, that the care home have written guidelines about what the appropriate way to administer medication to each specific individual person is. It's not something really that can be answered very quickly. I'll think about it and send a reply over the next few days, if you like.
That'd be great, Bernadette. But I think that is, to start with, a really good, ensuring that there are clear protocols in place within the care setting itself to ensure that even if there's a big changeover of staff, and then for the pharmacy maybe to have an understanding as well of the needs of particular patients in that setting. I think that is definitely a good starting point. Another question, are there any resources like pictures we can use in communication with patients with intellectual disability? Anything that any of you are familiar with? But
the Royal College of Psychiatrists has an intellectual disability section, and as far as I can remember, they have lots of guidelines. I think there's another group called MenCap, and they have easy read versions. The HSE website actually in Ireland has information on psychotropic medication, and they come in an easy read version. However, easy read, just it might be easy read for us and might be pictorial, but it might mean very little to an individual with intellectual disability. Some people like to actually, get the information from a person. Some people can access information that's written. Some people need to hear it. Maybe there are verb or oral sources of information. There's no simple answer really for people with intellectual disability. In the centre I work, I find a lot of them have iPads and apps and things now. So there might be some way of downloading something like that would be a resource. It is something that has to be researched. I think the Daughters of Charity years ago were doing some research into producing accessible technical sources of information, but I can find out. I never heard that anything happened.
Okay, thank you, Bernadette. So Audrey has kindly shared the feedback link in the chat there. We'd appreciate any feedback that you have. So I'll take this as a final question before we close off. Is there any data on infection rates and antibiotic use in patients with intellectual disability? Máire and Juliette, I'm not sure if you've come across anything like that in your research.
Because we gather the medication data, we generally gather is phrasing as medication you use on a regular basis, like every day and every week. We wouldn't actually gather antibiotic use. I know just offhand that there have been high levels of H. pylori reported in the population, some of it I think to do with living in congregation settings, and I could send with the link afterwards. Did a specific study looking at the experience of COVID for people with intellectual disability and COVID infection rates.
Thank you, Máire.
Yeah, I think there's a very high rate of chest infections, respiratory infections because of the dysphagia. A lot of people actually inhale pieces of food and liquid, and this results in respiratory tract infections. So from that angle, there is a significant use of those type of antibiotics actually. Also UTIs, you would find, depending on the care home, then again, and how well it's, that aspect of care is managed, you can have a lot of antibiotics for UTIs.
Okay, thank you. And there's a comment in the chat about choice in medication in the UK have leaflets which are easy read documents. So thank you for that tip. So just to flag, obviously, as always, we'd encourage you to undertake a reflective cycle based on this evening's presentations. They've been very informative, and we will share the resources with you afterwards because there was a lot of very rich content in that, and I'm sure you'd appreciate it to look at it yourselves. We will have a webinar next week as well. And I mean, I suppose slightly, I just think we tend to do them every other week, but next week it's to help us coincide with European Antibiotic Awareness Day on November 18th and to get us ready for that. So let's talk about antimicrobial stewardship, and that would be with Marie Philbin and Mala Shah. So we'll send out an invite for that in the coming days through our usual means, through email, Twitter, LinkedIn, and Instagram. So hopefully you'll be able to join us next week as well. So that leaves me to thank our speakers this evening. So thank you, Máire, Juliette, and Bernadette. That's been fantastic, and a topic that I've really wanted to look at for some time. And I hope people have found the content helpful for their practice this evening.